Hello, welcome to Converging Dialogues. This is Xavier Bonilla. On this episode, I have Allie Choate. Allie is a doctoral student in clinical psychology, and in this podcast, we talk about mostly psychopathology. We start the episode discussing the general definition of psychopathology. And then we get into a long discussion, which takes up most of the episode, about p-factor. We define what p-factor is. We talk about some of the internalizing and externalizing factors. We talk about p-factor as lateral with g-factor in intelligence. We talk about some of the intelligence components of G and how it's similar to the p-factor. We talk about which disorders load most on p-factor. And then we give a definition and explanation of personality disorders. We talk about the co-morbidity of personality disorders and other clinical disorders. We discuss her research on borderline personality disorder and psychopathy and some of the surrounding literature on this. We also talk about the bifactorial model and or factor analysis and how that's used to understand psychopathology research and borderline personality disorder research. We then talk about the current state of research in the social sciences. And then we talk about borderline personality disorder as an actual construct. And is it an actual construct? We also, towards the end, talk about dialectical behavioral therapy, otherwise known as DBT. Allie is a lovely person, and she is wicked smart. I was having to, kind of go back into the database in my brain and try to remember some of the stuff I had learned in grad school. So she was wonderful. And, this episode is really good and really important. I think it gets a little technical in some areas, which I personally liked. But I think that it's important to understand in general psychopathology, and then more specifically borderline personality disorder and personality disorders in general. People throw those words around in the general, public, and are typically misinformed about those things. And she is wonderful at explaining that, and just a lot of fun. And so now I bring you Allie Choate. I am here with Allie Choate. Allie, what's going on?
Not much. Just actually, it's kind of cold in Tampa. Honestly, I've been in blankets all day, which is pathetic because it's still in the 60s. But
I'm up here in Maryland, up here, I guess, in the north for you Southerners down there. So yes, it is. It's fine. It's January weather. So it's in the 40s, low 40s. So
that's not terrible, actually. I used to live in Chicago. It was much worse there.
Yeah, it's not so bad. Okay, so thanks for coming on. I'm really glad to have you on here. You get to share your knowledge with us, which I'm really happy about.
Yeah, thanks for having me.
Tell listeners just a little bit about yourself. So just say, just kind of what your probably academic background is, what you're currently doing at the moment, areas of research, specialty, all that kind of good stuff.
Sure. So I am currently a PhD student in clinical psychology at the University of South Florida in Tampa. I got my bachelor's in psychology from the University of Missouri, otherwise known as Mizzou, which I deeply love. And so currently I'm a fourth year, which seems weird, feel very old. So I'm almost done, but still kind of kicking through things little by little. My research interests are, I guess, more broadly general psychopathology and kind of the development of psychopathology, but I've also done a lot of personality disorder research, particularly borderline personality disorder, and dabbled a little bit in substance use as well, things of that nature.
Okay, that's great. And when you finish, you're almost there. You'll get there. It's fine. What do you hope to do when you get out and you finish?
That's a really good question that I've gotten a lot with the holidays recently.
Oh, okay.
And honestly,
sorry to bring up a sore subject.
No, it's good because it makes me honestly reflect more, because it's like, being in school for so long, you kind of forget that you can have a real job, and the end is in sight, even though it still feels very far away. So I don't know, thought about this a lot recently. I used to really want to do some sort of research job, whether that was academia or working in like a research hospital kind of setting. I've kind of gotten away from going academic. I've gotten, I don't know, less enthusiastic about academia over the past couple years in particular. So
Yeah.
right now, I don't know. I mean, I've considered doing some sort of like forensic psychology stuff, whether that's evaluations, so like child custody evaluations, or working in the court system. I think would be really interesting. I've also considered going into consulting. My job right now, I basically work for a pharmaceutical consulting company in good old corporate America, which has been super weird in the sense of it's just so different from everything I'm used to. But it's been super refreshing and actually really nice, because I think big pharma has a lot of negative connotations, and it's been nice seeing the other side of things and realizing that yes, there are definitely some negatives, but there's also a ton of positives that I don't think the general population knows about. So kind of entertaining that route as well. So we'll see, I guess.
Nice. Yeah, that's great. I think I had I had a clinical psychologist on here recently, and we were talking, and one of the really nice things about the clinical psych world, which is, I don't know how much people know this or think about it, but you can do many things. You can work in many places. It's not just, do people come and lay on a couch and do talk therapy, although that's a staple of it. There are so many avenues for clinical psych folks, and so it's nice to hear different people in different arenas. And so yeah, I mean, big pharma is kind of the evil empire, but for most people. But I think that having good, smart people there on the inside is also really helpful as well. So yeah, it's nice to see fellow psychology people in different fields and different areas. So that's nice to hear, and be curious to see what where you end up. So
Me too.
you don't have to have it all figured out. It's so crazy once you finish. It's just like, oh, it is a nice feeling, but it also is very anticlimactic as well.
Okay, good to know.
It's good. It's a very, very nice feeling. It's a big relief, but then it's just like, oh, yeah, that's done. I just spent a long time doing something, and now it's done. And then it's, on to the next stuff. So,
Exactly.
but that's great though. It's really good. So, okay. So let's hear about what what you've been doing for 2, 3, 4 years, I guess. Let's start, I guess, with, I've kind of been saying this with some of the clinical psych people I have on here. Most of my guests are social scientists. So I've had a handful of sociologists. I've had some social psych people. I've had some writers, and also have some philosophy people. And so, some people would say like, "Oh, we want to hear you do more clinical psych. Isn't that your world?" And so it's always kind of home base for me when I do. So maybe just say generally for listeners, what is psychopathology, and just very broad, right? What is it, and why is it important, and why do psychologists spend all their time mostly thinking about that? And yeah, let's start with that, and then we can kind of get into the more details.
That's a great question that I think no one really agrees on, which is the funny
Sure,
thing
yeah.
about it.
Yeah.
I mean, I think broadly speaking, most people just define psychopathology as, all of the mental disorders, all the symptoms that make up all of the things that we define as mental disorders. And we're interested in, of course, treating these things, these symptoms, and kind of finding better ways to prevent them, and, finding their etiology and all of that good stuff. But I think psychopathology, the study of psychopathology, has really progressed over time, definitely for the better, I would argue. But I think we're still kind of in this weird state, particularly with kind of these advancements in statistics, where, for instance, I think the big thing right now that's super popular is, again, like the general factor of psychopathology, or people just refer to it as the P factor. That's kind of like, there's been a surge of research on this factor, and it's, I don't know. I have mixed feelings on it, because I think a lot of the literature suggests that it's kind of this overarching causal entity that's supposed to capture, an individual's predisposition towards developing all these different forms of psychopathology. There's a lot of other theories and kind of debates that kind of go against this and suggest that, for instance, this could just be a statistical artifact, or perhaps
Mm-hmm.
it's the result of shared dysfunction amongst disorders and so on and so forth. So I think there's a lot going on that's interesting and that's good, but also just a lot of different perspectives that aren't necessarily all being weighed equally. So I think that has kind of led to a lot of different clashes on this topic.
Mm-hmm. Yeah, I think that's right. So I would agree. Psychopathology is just where things go wrong with the human psyche and with folks that have enough dysfunction for it to quantify as a mental illness. So the example I usually give is, well, everybody gets depressed, right? Or they have depressive symptoms, would probably more accurate to say. People feel anxious. Some people feel high energy. If you look at just the symptoms, and even if you have a collection of symptoms, that's somewhat normative, right? I mean, you've
Yeah.
felt anxious. I felt anxious. You felt, sad. I felt sad. There's certain symptoms and certain mood states. I think the key part of psychopathology that makes it that, as opposed to just different mood states that average folks will have, is that it has to cause some type of significant impairment in occupational, social, vocational, academic settings. And usually there's time limits around it. But the big thing is that it has to cause significant impairment. So are you not able to work very well? Are you having, just catastrophically terrible interpersonal relationships? And is there any physical or organic issues, sleeping, eating, where these mood states or these different types of a constellation of symptoms are impacting one's ability to function well? And that's maybe kind of the generic standard. This is what is just normal shitty day or shitty week, from no, this is maybe mental illness. And so you're bringing up the P factors. Okay. So before you launch into that, typically within both you correct me if I'm wrong here, but my understanding is that within the psychological literature, both historically and I think still currently, maybe there's debate about that, this is a very crude, loose uh, um, ratio here. But most people, in terms of development of humans, attribute our uh, personality development and who we are to somewhere 50-50, the whole nature nurture, right? That
Mhm.
there's a component that is genetic and or biological, and there's another component or components that are based in our environment, based on our social standing, and based on um, interactions with others. And so as we're developing as people, there's somewhere of, maybe it's 60-40 one way or the other, or maybe it's, somewhere 50-50, but it's somewhere close to a sort of even split on how we develop. And so I don't know if that's still current or if that's your reading on it as well. So, if so, then maybe you can explain how the P factors kind of work in here.
Yeah, I mean, I think that's still accurate today, and I think that's again the funny thing about the P factor is it's just so broad, and it's just people kind of lump all of these things together because I mean they're very difficult to parse apart, and I think
Hmm.
that's inherently a problem with all of psychology is you just have so many different pieces that are working together,
Hmm.
and a lot of these analyses are based at the between person levels. You're just looking at aggregate differences
Hmm.
and you don't really get the full picture. And I mean, to be honest, it's really, again, it's difficult to measure a lot of these things that would be relevant to kind of understanding environmental influences and genetic influences and all of these things at once.
Hmm.
I know a lot of researchers really like twin studies and behavioral
Yeah.
genetics, and they think, those are going to solve all of the problems. But
Hmm.
I mean, even like just thinking about twins, like twins are inherently kind of different from the average person. Like
Hmm.
I would argue, anyways. And so I think, again, what people are suggesting is that because this P factor is so robust and it's been replicated in adolescents and adults and children using a bunch of different measures, community, clinical samples, all of that stuff, that there must be something there. But I mean, maybe that is true. I don't know. But again, I think we often just generalize what that factor represents. So again, we're just assuming that there's these underlying genetic commonalities between mental disorders. And I guess there is some evidence of that from, twin studies and whatnot. And we're also just, again, lumping these environmental influences all within the same bubble and then kind of calling it a day, which to me, is interesting, but also doesn't really get us anywhere at the end of the day.
Yeah, no, I hear you. I mean, well, the replication crisis, if you will, in the social sciences and definitely in psychology is a serious concern, which I've mentioned here before. So, I think if something does replicate, that's usually a good sign, right? That's usually nice to hear, especially more recently. But so give us a definition, I guess, of what the P factor is, what it's looking at, how it explains certain things, kind of the power behind it. Yeah, just kind of give us a kind of operational definition, and then kind of the particulars about what it looks like and why some people really like it and everything.
Okay. I guess so basic history, there used to be the internalizing, externalizing model, which if you know anything about clinical psych, most people I think have heard of that, where you have,
Mhm.
The internalizing dimension that kind of gives rise to anxiety disorders, depression, things of that nature. And then externalizing is kind of those antisocial behaviors, substance use, things like that kind of get under that umbrella. And so a lot of studies that were looking at these two dimensions found that they were kind of positively correlated. They typically correlate, I think, around like 0.5-ish or so. And so that kind of gave people reason to believe that, like, okay, well, maybe there's an even higher dimension that kind of is responsible for why these two seemingly opposite dimensions or domains are correlated. And so that kind of led to people using bifactor models primarily, which, just very briefly, bifactor models basically separate any sort of communal variance, between whatever constructs you're looking at versus the unique variance that's separable from the general factor. And so the idea here is if you have a robust general factor that emerges from your data, that is, I guess, evidence that there could be this, again, like overarching general factor that's kind of responsible for the emergence of all these different symptoms. The problem with that, of course, is there's a lot of different explanations as to why you might get this general factor that kind of comes from your data. So actually, there's a really good paper that my thesis is really primarily based on that came out of the intelligence literature that kind of discusses this issue, particularly with the general factor of intelligence. And so kind of the same idea where
People love talking about IQ. They love talking about intelligence. And I'll just briefly interrupt here. There, I don't know if you follow some of this stuff online or in Twitter or all these things. People go nuts with race and IQ, which we can look at that and not touch it if we don't want to. But in general, though, with IQ intelligence, people have issues just in general with that, which is always fascinating to me because I don't like being the kind of gatekeeper or guardian, but it's very funny to me where there are many non-psychologists that are talking about intelligence studies, and it's like, I'll just say this: I wouldn't talk about law because I'm not a lawyer, right? I wouldn't talk about medicine if if I'm not a medical doctor, specifically. So it's strange to me how people are very animated and they read a couple studies and they know a lot about intelligence. And I just see a lot of inaccuracies. So help us wade through this, educate us, I guess, on the intelligence piece of this.
Yeah, no, I would agree. It is a very hot topic issue, and I really wish it wouldn't be because I mean I get it. It's sensitive in many ways, but also there's just so much to discuss that I think is worth discussing that gets kind of shoved aside because people don't want to have that conversation. But
yeah, I agree.
Anyways, related to the B factor, I think the idea was, again, like there's a lot of people that think, Spearman's basic G factor of intelligence, right? That we have this overarching factor that somehow causes different cognitive ability or, whatever we use to measure intelligence to emerge. And so this was kind of translated to the P factor as well, where again, you have this overarching latent vulnerability that causes these different set of symptoms to kind of unfold over time. And so a paper by Vandermoss, that's how you say his last name, hopefully, and colleagues in like 2006, they put this idea of dynamic mutualism theory. You may have heard of it, not sure. It's not like, I think it's becoming more common. I mean, again, I'm not an intelligence researcher. So from my understanding, at least looking at different papers that have been published, it seems like it's being a little bit more common or more commonly entertained. But there's a couple papers that have also kind of translated it to the p-factor as well. But basically what dynamic mutualism suggests is rather than there being kind of this overarching factor that causes either, intellectual ability, psychopathology, whatever it is, to emerge, and this factor instead is kind of the product of these lower level interactions, whether they're interactions among cognitive processes that begin to form early in development. And the idea is that these processes form strengthening associations over time. And these increasing relationships basically are reflected in the general factor when you model them through something like a bifactor model. So basically the idea of this positive manifold, which is just, again, a set of highly correlated indicators, will produce a large, or I guess, robust general factor when it's modeled that way. Hopefully that makes sense.
Yeah. So if I'm understanding correctly, the P factor is supposed to be not a replacement for G, but a more of a higher correlatory factor it kind of transcends the G factor, right? Like it could be it has more correlation than just what we understand with Spearman's G, or am I misreading that?
So I think it's just similar, like it's a similar idea as the general factor of intelligence, just applied to psychopathology.
Okay. So whereas so they can coexist. So if G is for cognitive abilities or intelligence, the P factor would be for maybe not personality functioning, but more so of when very colloquial way, when personality goes wrong, or when there is potential psychopathology, right? So for listeners, if G is the unifying central variable for understanding someone's intellectual or cognitive abilities, the P factor would be what is this factor that is central for understanding different predispositions for psychopathology. Is that about right?
Yeah. And it's actually interesting that you brought up personality too, because there are different studies that have looked at, I refer to them as just common axis 1 disorders. So, depression, anxiety, bipolar disorder, things like that, and kind of looked at personality disorders separately. And then there's also been people who've looked at general personality as well. And so it's interesting because, again, I think there was a paper recently that looked at these things and found that the just general factor of personality, I think they had like, neuroticism, agreeableness, things like that.
The big five.
General factor of personality disorders, and just the general P factor, which again, those common axis 1 disorders were all like very highly correlated, which was interesting. And their kind of interpretation was that, the P factor isn't necessarily this causal entity. It could be instead a product of shared dysfunction that kind of happens with various disorders. So, bipolar disorder may have nothing in common with anxiety disorder, but they both relate in maybe similar levels of distress or dysfunction. It's actually probably a bad example, but you get what I'm saying. So instead, it's just kind of a summary of shared dysfunction or impairment rather than the cause of it.
And so I think that's important because for G factor, I haven't thought about this in a while, but G is basically I'll just rabbit trail real quick for a minute. G is basically the central variable for understanding a person's cognitive abilities. So you have who came after him that did the two. You have crystallized and fluid intelligence, right? And there's different ways of understanding basically what you learn and what you know. And for G, it's kind of what you have if you do psychological assessments, where you have a full scale IQ score. It's basically the central thing that says here is the one variable that says this is your overall or general intellectual ability as a person, which has biological and genetic loadings. Not exclusively, but it definitely has a significant amount. I think slightly people get upset about that because then it says, well, I can't change it. So if if my IQ is 100, which is a fine IQ, it's dead average, according to weight scales, of course, Woodcock-Johnson cognitive abilities test has a higher threshold. I think it goes up to 185, right? Something like that. You have, dead average 100 on the waist. So, the main intelligence measure, there's nothing I can do. If my G factor is somewhere around there in the average range, well, I'm just average intelligence, which is totally fine. Like that fits within the normative, Western culture. Most people have that. Not everyone's going to have a 118 IQ score. And so people get upset about that, right? Because if you have a low score, it's just basically saying I'm not so bright as I want to be, and there's nothing I can do about it, right? And this is why people get upset. And then, so is it sort of the same thing for the P factor? So one quick thing before you answer that, most people kind of look down or have a judgmental notion of personality measurements because it's very historically has been there's at least 4 different models, and I'm forgetting all of them. There's the theoretical one or the atheoretical one. There's different ones that have empirical elements, but most people look at personality stuff as more qualitative, right? If you go far back, you look at Carl Jung's, Myers-Briggs stuff, which is, kind of garbage statistically. It doesn't really have validity or reliability. But and then you have like other measurements, Rorschach, or even if you have stuff like MMPI, these are all kind of the assessment measures, and they still have a qualitative component. And so I think the nice thing, or the limited things about P factor, is that it gives you a quantitative analysis of something like not personality per se, but definitely about psychopathology. And some of the problems that people have with clinical psych, at the very least, is that, well, yeah, but psychopathology there's too much gray, right? It's too much determinant based on, how things can change or how the clinician is evaluating them, or, there's too much. It's too, it's not quantitative enough. There's no hard science as much behind it. And so P factor can give some really good data to show, wait a minute, yes, there is. And I think maybe that's why people really like it. How do you see it?
I would agree with that to an extent, for sure. And in some cases, I think it really ultimately boils down to how you're interpreting it. Personally, do I think it represents something that's causal in nature? Me, probably not. That's just my personal opinion.
We don't like causation. Or we do, but it's hard to find.
Right. And it just seems, I don't know, seems a little far-fetched. But do I think that it can still have utility? I mean, sure. I think from kind of what you were suggesting, there is evidence that higher scores on the P factor do predict kind of these important clinical outcomes and, different cognitive correlates even. And so, that is information that could be useful. I think a lot of people are also looking at it from a therapy perspective and saying like, okay, well, if there's kind of this global thing, can we devise these transdiagnostic approaches to kind of target this, which one, from a cost-effective standpoint, might actually be really awesome. And two, might be, again, easier to kind of deliver this treatment modality in different contexts and stuff if you're really just kind of targeting one giant glob. But however, what that glob, that's a horrible word, but the first thing that came to my mind for some reason. But whatever, figuring out what that even represents, though, again, it opens up a whole nother can of worms. So again, I think I mentioned earlier, some people think that the P factor is more of an outcome of having psychopathology. Other people think, again, it's more of like just a statistical summary. So again, if you are having a lot of symptoms that are kind of interacting and feeding off of one another, those increasing correlations are going to get captured somewhere, which very well could be the P factor. And, so that doesn't really mean anything at the end of the day. Other people suggest that it is a substantive construct, and basically what it could represent would be something like neuroticism or emotion dysregulation. Borderline personality disorder has been proposed as a marker of the P factor. Like everyone's theories, there's just a lot of them, and kind of converging on which one might be most accurate has clearly proven to be difficult.
Yeah. So, well, the joke is that psychologists are so good at overthinking everything.
Probably accurate, to be honest.
Excuse me. And I guess so. If there's this general kind of factor about how do we understand psychopathology, how do we know that, or how do we measure that, or how do we get that, right? So let's try and put it, I guess, in more layman's terms. If there's a series of measurements or certain tests that are run to show that, hey, this person is more predisposed to having, depression or bipolar, or, that's kind of at an individual level. But how does it, I guess, actually get measured, and how does it work, and all of that?
Yeah, it's a great question. I think generally speaking, most studies have just been based on self-report measures, which
Hmm.
are problematic in
Oh
many
yeah.
ways,
Oh yeah.
and a lot of our measurements are kind of garbage, to
Oh
be
yeah.
honest,
Oh
and
yeah.
aren't
Oh
super
yeah.
reliable or valid, or
Yeah.
I will say there are more studies that have been at least doing like multi-informant reports, which is nice, of getting the kid to report and the parent or the teacher or something like that, and they've also found kind of converging support
Mm-hmm.
within those different reports. So that's encouraging. But I mean,
Mm-hmm.
yeah, definitely across the board, I think most studies are just basically using self-report measures. Some do clinical interviews. That's been a little bit more common recently, but and I guess those studies have also kind of found similar evidence that the self-report measures have found. So that's, I mean,
Mm-hmm.
great. But again, there's kind of some problems with those things as well. There needs to be kind of some more behavioral. I'd like to see some more behavioral measures incorporated in these studies in the future.
Mm-hmm. And so once this data is collected, I mean, and is this done with undergraduate students and like Midwest universities or whatever,
I
or
think there's,
is there a
yeah,
good robust sample size?
I think fortunately, because it has attracted so much attention, there has been a lot of data that is good, a lot of longitudinal data that's decent. I mean, again, like by decent, we mean 2,000, 3,000 people, which
Yeah,
for psychology is a decent
psychology. That's
sample.
nice. Yeah, that's nice.
Right. But it's so funny because I talk to friends of mine who are not in psychology, and I say that, and they're like, how do you ever expect a sample of 2,000 people to generalize to anything? And I'm like, that's a funny
Mm-hmm.
point.
Yeah. Yeah.
But for us, that's a big sample size. I don't know.
Oh yeah.
Uh,
Yeah.
so, but yeah, so they've had a lot of developmental data. They've had, I mean, some of it is not the best. I'm sure there's been a couple of college samples here and there.
Mm-hmm.
Other epi samples have been used. So it's decent. It's definitely better than I think a lot of areas of psychopathology research for sure.
Mm-hmm. And so I guess a little more specifically, so where does the P factor load in terms of, well, I guess I should ask this in the reverse way. How much was DSM-5 using this, if at all? If
Um,
even.
that's a good question. And I'm not sure if I have an answer,
Okay,
honestly.
that's fine. So the DSM-5 Diagnostic Statistical Manuals, it's in its 5th edition, which is now, can you believe it, 8 years old already? It's crazy, right?
That is weird. Yeah.
Um,
Makes me feel old.
yeah, I remember DSM-4, so I feel.
I like DSM-4 better, actually. I like the Axis system. I just thought it was
I
nice.
have, I don't know. I don't know. Yes, I like the access system as well, but I really, really have adapted and really like the multidimensional system. I think conceptually it works better.
I agree. I more
But
so just liked the axes
the
because it
axes
was
are just
easier to
easier. Yes.
talk about them
Yes,
too.
yes,
Because it's
yes.
like, oh, axis one versus axis two. It's
Yes,
easy.
I'm
Done.
with you on that. Because there really is like kind of void that's left there when you're doing diagnosis. Because it's just like, well, what order do you put this in? It's like, well, whichever one's most important. It's like, well, then why don't we just have an access system again, right? It's just,
Hmm.
So I think some people still think that way, but and that was how we did things for a while. But okay, so what about in terms of disorders? So maybe this starts branching off into personality stuff, but let's start with your old school Axis One stuff first. So um, I guess the big ones for uh, psychopathology, if you're using a kind of the criteria from the DSM, is that you have basically you have mood disorders, which have 2 subsets now as a new addition to the DSM-5, which is you have depressive disorders and you have bipolar disorders. Bipolar disorders are bipolar 1, 2, cyclothymia, and I guess the otherwise specified and the other holdover. And then major depressive disorders is major depressive disorder. It's
You have like persistent depressive
the
disorder now or something.
dysthymia. Yeah, that's right. And the new one persist. Oh my goodness, disruptive mood dysregulation disorder, and I think there's like 1 or 2 others. Anyways,
So
so
many.
that's like, those are the mood disorders. You have anxiety disorders. I'm not going to list all the anxiety disorders, like 7 or 8 of them. Um, um, psychosis disorders, so schizoaffective, schizophrenia, schizophreniform, brief psychotic. Yeah, and I guess like all the eating disorders, sleep disorders, sexual disorders. What am I missing? Mood, anxiety, psychosis. I guess the uh, neurodevelopmental, and then you have the neuro cognitive ones. So your Alzheimer's and all that stuff. So there's that whole kind of the old axis one, all those fit under there, and the old axis two would be the personality disorders. So with the P factor, with the where does it kind of load heaviest, or where is it most has the highest correlation or biggest impact in terms of either the groupings, right, or particular disorders, or where does it load highest?
Yeah, that's a good question. And I think it also depends largely on what's put into the model. And that's kind of, I think, a large issue is a lot of these studies aren't consistent with the types of psychopathology indices that they're feeding into the model. So obviously your results are solely based on what you're including. So if you're missing psychosis, for instance, which a lot of studies are, then
Right.
you're not going to get a full picture of what's going on. I will say, I think one of the seminal papers that looked at this in adults found that psychosis, kind of this like thought disorder dimension, loaded strongest on the P factor. And I think that has been replicated in a couple other studies. But again, like other studies using adolescents often find that like ADHD kind of comes out to be the top performer. And then if you look at personality disorder research that are exclusively just entertaining personality disorders, I also realized I might have jumped the gun here. Getting into
No, that's okay. No, it's okay.
Okay.
It's okay.
So borderline personality disorder usually comes up on top, and it loads highest on the P factor. And then if you combine these things, which people have finally done very recently, this has only been cross-sectionally, though I'm not sure how this would unfold longitudinally, but in one recent cross-sectional study using an epi sample, they found again that Bpd kind of was again the champion, if you will, and also had the strongest relationships with the P factor above other kind of common mental disorders.
Now, I wonder with that, not to rain on anybody's parade, but is it because those are the most common disorders, or those are the ones that have the most subjects? Those are the ones that you see more often. So like ADHD is like, that can't be hard to find folks for those studies. You could break it down probably further with adolescent, child and adolescent ADHD and adult ADHD. Within the personality disorders, out of the 10, borderline is the most common, right? Epidemiology studies, I think borderline is the most common. And then thought disorders. Again, you see this, but that, if you take like a just kind of classic schizophrenia, those are where all the twin studies are, right? So there's a lot of historical data on that as well. So I wonder if those things load well because there's a lot of data on that, right? Like you're not going to see a lot of stuff for like bulimia or sleep apnea or something, right?
Yeah, I think some people make the case that the most severe disorders are going to load the highest on the P factor. People also make the point that disorders that tend to be comorbid or co-occur with other disorders like Bpd in particular are going to load higher, since P is supposed to, reflect all these different relationships between disorders. So it would make sense that if you have a disorder like Bpd, or even, depression, anxiety tend to co-occur with a lot of different stuff, then those things would load higher on P as well. I also think disorders like ADHD that have overlap with other disorders, so like concentration issues, you see in ADHD and depression. So disorders that, again, share more in common with other disorders, kind of that criterion contamination issue, also probably going to load higher. I mean, some studies do account for that and make sure that there's symptom overlap is kind of taken out before running the models. But again, that's, I think, a small subset of studies that have done that.
Yeah. I teach first year grad students, and I do like the psychopathology class. And one of the things I'll tell them is you have to look at symptoms before you think about disorders, because a symptom can be in any, if you take something like inattention, that could be ADHD, that could be depression, that could be anxiety. And so the behaviors you're seeing, if you list it as a symptom, inattention doesn't automatically mean ADHD. That's why you have other criteria. You have to understand the kind of gestalt of it, the whole picture of what things are, and timelines and severity and everything like that. And so so kind of like what you're saying, there's this kind of symptomatic cross contamination between, like, well, one symptom can be in a variety of other disorders, and or it could be comorbid, meaning that that people have two disorders, right? So it's not uncommon that people that have depression also have generalized anxiety disorder. That's not uncommon. It doesn't load, the p factor doesn't load on the bipolar or depressive or anxiety disorders, or just less so than the other ones.
I think they still have decent loadings for sure, but I think kind of, again, those more psychosis related BPD, ADHD, I think there's been some studies that have found like conduct disorder, like ODD, to also load pretty high. For the most part, across the board, they all have like moderate loadings on P. Like, typically when people are looking at these things, most commonly they model the P factor in the context of internalizing and externalizing. And I think there's like 2 or 3 studies that have found internalizing and externalizing to still capture a sizable proportion of the variance. But I think across the board, it's always the P factor captures a ton of variance. The specific factors are not interpretable. The end, so.
Right. Okay. And so, do you want to tell us about personality disorders? We can
Sure.
we can still stay on the P factor element, but we can broaden out, or maybe we do that first. So for listeners, so because I will say this, I do think it's important and instructive, and you would know more than I would probably. I don't do personality disorder research.
You're smart.
I don't treat folks with personality disorders either. I have. I don't. There's this weird thing when you work with those folks clinically, then you start to become that person that does personality disorder treatments, and then that's all you get all the time. And so I have done it, but I don't market myself that way.
Fair enough.
I had a professor though that he did 35 years working with borderline personality disorder, or folks with borderline personality disorder, and yeah, the man's patience was incredible.
Yeah, that's impressive.
Yeah. So, okay, so why don't we tell listeners just kind of the very easy form of what personality disorders are, and what the 10 are, and how they look different, and then we can maybe focus on borderline, because I think that's the one you've focused on the most.
Yeah, definitely. BPD is definitely my most known for sure. Sometimes I forget about the other personality disorders in general, honestly, especially like dependent, avoidant. Actually, this is slightly off topic, I guess, but I got into a long debate with someone on the differences between avoidant personality disorder and like social anxiety disorder, because I didn't realize how much they overlap. Like, if you actually look at the specific criteria, it's kind of insane, actually. Like, I get the broad differences, but I'm like, how do you distinguish these two things?
Yes. I'd have to look at it again. I remember sitting down and learning the differences between avoidant social anxiety and there's another one. There's three disorders that overlap, I guess. So the thing that's interesting with it is, so some people have some serious qualms with a disorder of personality, put it that way. Do you remember off the top of your head? I don't. I always look at the DSM, but there's the 4 major criteria for all personality disorders. And so in this way, personality disorders are all the same. So I have a strong affinity for Freudian psychodynamic conceptualization. I don't. Do you? Are you? Are you?
My lab mate is obsessed with Freud. Obsessively obsessed with Freud.
Obsessed. I do respect him a lot, but
where do you land? I think it's half of it is a joke, but half of it is serious. And so I sometimes channel Freud, I think, through her, honestly. But I respect him a lot, honestly. I think he did a lot of really cool things for the field, and we owe a lot of our advancements to him. But so in some respects, I think, like in intro classes, they put way too much of an emphasis on Freud. But at the same time, so many people in the field discredit him so much and don't give him the respect that he deserves. So I don't know, but I think it's fun. Psychodynamic theory is fun at the very least.
But I mean, you do clinical work, right? So I mean, you don't psychodynamic, or you more CBT, or you don't have
I
one?
mean, oh my gosh, if our program did anything psychodynamic, I think our clinic director would have a heart attack. We're primarily, I mean, most of our stuff is all CBT, DBT, all very empirically heavy driven modalities.
Mm-hmm.
Personally, I really like CBT. I have respect for DBT, but it's not, if they're so similar, honestly, at the end of the day, but some of their differences I think are, I don't know. I think the more logical aspect of CBT I identify more with versus DBT has a lot of touchy-feely elements that I don't jive with as much.
Mm-hmm.
So, I mean, that's just me personally, though.
Mm-hmm. So yeah, I don't know. Do you remember there's four major criteria of personality disorders? Again, I don't work.
I really, I should know this.
I don't remember.
But I don't.
I know it's something.
I don't remember.
I know it's something with it's interpersonal issues and interpersonal challenges. All right, I have my DSM. I'm only going to read this just because I think it's helpful for listeners, and I don't feel like trying to have to remember what it is. This is literally what all clinicians and psychologists do. They just look at the DSM. They don't have it all memorized. So the four, I'll just list the four. To have a personality disorder, it's the enduring pattern of inner experience and behavior that deviates significantly from expectations of individuals' culture, and at least two of the four areas. So cognition, affect, interpersonal functioning, and impulse control. So when you think about there's 3 clusters and 10 disorders within personality disorders, and they all have to fit that general criteria, what I just read. So, I mean, I don't know how much research you've done onto it, but I guess just the concept of a personality disorder. I mean, how much do you think about that? Is it bullshit? Is it just an antiquated thing? Is it totally legitimate? And how do we, what are your just general thoughts about it, I guess?
I think there are aspects of personality disorders, personality pathologies, whatever you want to call them, that make sense and are reasonable and deserve attention in research and clinical practice. But I think there's also components of it that are a little bit more difficult to, I guess, grapple with. I think especially from a clinical versus research perspective, because, if you look at just, a random individual and they have X personality disorder, a lot of time those kind of traits that we're looking at and that we're classifying as disorderly in some ways are adaptive, or in other ways are really not what we would consider pathologies, but they still get grouped under this category. Like I think of psychopathy as a great example. And even though psychopathy is not technically even recognized in the DSM, I think of a lot of aspects of psychopathy on the surface level are not desirable characteristics, but at the same time can be very adaptive. And like some of the most successful people are very, very high on factor 1 psychopathy, which is your typical callous, unemotional qualities, narcissism, things like that kind of get grouped into that. So I think over time we've shifted in personality disorders and we've looked at them more dimensionally, which is great. And we've kind of stopped this idea that if you have a personality disorder, you're stuck with it for the rest of your life. Like that whole idea has changed over time. I think in the general public, it has not. It's like if you have a personality disorder, then you're screwed.
Right.
But at least in research, we're kind of recognizing that these are more dynamic than we expected, and that these things change over time, and they're not necessarily stagnant, which is good, I think.
Yeah, I would agree. So, yes, I think historically that's how it was thought, and then it's like, okay, I think there's still a challenge people have of saying that your personality is disordered. And I think, I can understand that, but I think it's more of, typically folks that have a personality disorder have, I'm not going to make a generalized absolute statement, but many of them have some early childhood traumas. Not all, but many, or there are very big life markers or experiences that are very transformative, usually early in life because it's early development. So, and that kind of sets the course for human psyche and our personality. So that's usually why that's usually in that time frame. Yeah. And so, I think that's, and there's overlap, right? People that have personality disorder have, comorbidity, other disorders such as bipolar 1, I think is the most common with borderline. Am I wrong on that?
Actually,
Might be wrong on that.
I think it depends on which estimates you're looking at. I think that it's interesting because a lot of times BPD is mistaken for bipolar and vice versa, which I always,
Mm-hmm.
on the surface level, find strange. But I think particularly if you are, like a general practitioner or a psychiatrist or something like that, I think a lot of those reported mood shifts that you see in BPD often get grouped into, oh, well, these must be, bipolar mood shifts when it's really
Mm-hmm.
not the case.
Mm-hmm.
And also some of the other behaviors that get associated with BPD, like kind of those impulsivity, risk-taking behaviors.
Mm-hmm.
Sometimes I think it might get confused for behaviors people might do if they're in a manic or hypomanic episode.
Right.
But I mean, overall, BPD is prevalent in ADHD, depression, anxiety, antisocial personality disorder, other personality disorders, eating disorders, particularly binge eating disorder, or not binge eating disorder, sorry, bulimia. I think maybe binge eating disorder too, but definitely bulimia. And the list goes on.
Right.
So,
do you know the rates, general epidemiology rates? I can't remember what they are. I know it's very low. Like, what is it, 4 or 5%?
2%. Oh, maybe it's higher than that. Shoot, I just looked this up. I have this literally in a paper I just was looking at too.
It's okay.
I want to say they're like 2% ish.
Personality disorders in general, right?
Yeah. I know they're obviously elevated in clinical populations.
Sure.
But
in terms of the general population, it's just so rare. This is just, again, one of the things that really frustrates me is when people will start kind of throwing that around. It's like, you just don't see that very often. If you have 350 million people, you're not going to, you're almost never going to run into it. And yeah, I mean, when I worked inpatient, we didn't see it that much. We did see it, but it was not every other patient. There's whole units of people where that wouldn't be there. So it's not as common as people think it is. And I think on the clinician side, one of my huge pet peeves is where people will be very quick to, they'll see one or two traits or something and quick to say, oh, this is borderline or this is narcissistic or whatever. And it's like, no, we have to be more prudent about throwing personality disorders around for people, just because it's not seen that often. But
yeah, no, that was my experience too. Any patient that tended to be a little bit more difficult to handle or deal with, or more severe, it was very common for them to get slapped as borderline. And I don't know, to me, I always thought that was kind of concerning. Like, I mean, I get it, but at the same time, it's, again, I agree, we need to be a little bit more careful before we apply these labels to people.
Yeah.
And do a little bit more digging, and also kind of check our own biases, because I think BPD in particular tends to have a really negative reaction from clinicians across the board.
I think I've only, and I think it was when I was an inpatient, I think I've only diagnosed 2 or 3 people with a personality disorder. I'm very conservative. I'm very conservative with that stuff because I just know it's a label. This is going to follow someone for the rest of their life. You don't want to have a personality disorder, especially for what you're just saying. There is a very negative kind of animus, even with some clinicians, about, so you get someone's file and it says borderline personality, people run the other way. So, and if that's not accurate, there's a lot of, I think, responsibility for stuff like that. Okay. So tell us, I guess, your work with borderline, particular.
Sure. I mean, I've done some random stuff. I think I started in a BPD kind of substance use blended lab. So I think I originally was kind of looking at different alcohol expectancies in people with BPD. In grad school, I kind of dabbled in, I guess, a couple different areas. One area, primarily, I was looking at the development of BPD and other forms of psychopathology, primarily just like typical axis 1 disorders like depression, anxiety, ODD, ADHD, things like that. And that was in the context of the P factor. So kind of examining how BPD influences these relationships, and also kind of documenting how BPD and the P factor are related longitudinally. I think, like I mentioned earlier, there's been one study that have looked at them cross-sectionally, or looked at the relations between the P factor and BPD cross-sectionally, but there hasn't really been any longitudinal work other than, or I guess I should say longitudinal work starting in earlier periods of development. I guess there has been, I think, like 1 or 2 longitudinal studies that have looked at BPD, but again, in the context of other personality disorders, not looking at how BPD interacts with other just kind of common mental disorders, if you will. So that's been like my primary thing. I've also kind of looked at different gender differences in BPD and psychopathy, which is a very strange aspect of research or kind of field of research that also has a lot of.
Yeah, because I think it's just, I can't remember the ratio of this, right? But doesn't borderline trend slightly more female? Is that right?
Interesting. So
Or is
a
it
lot
equal?
of, so it depends on what study you're looking at. Because I think Tim Troll has a study using NESARC data, so epi data, that basically says it's equivalent rates in males and females. But there's been prior research done before that suggests it's more prevalent in females versus males. And there's also, I think, some IRT studies, so item response theory, that have kind of looked at gender differences in specific borderline criteria, and that have found a couple items tend to lean, or I guess tend to be biased towards females rather than males, which
fair.
I mean isn't entirely surprising, I guess.
Yeah, no, that's fair. I knew it was at least equivalent, so 50-50, more or less, or just a little more female. But then how does that load with psychopathy? Because isn't psychopathy mostly male?
Exactly. So there's
right.
Yes. So, and this is like the weird part where this is like an old issue that has been rehashed a couple times, but there's a lot of issues within the psychopathy literature in general.
So 100%. Yes.
Yeah.
Absolutely.
Yeah. But there was, I think, I forget whose theory this was technically, but there used to be this idea that BPD was like the female expression of psychopathy, and that's why there was such skewed gender differences. And to me, some aspects of that make sense. I don't really agree with that statement 100%, but I do think that, if you look at what psychopathy represents and those different criteria, particularly like factor 2 traits, where you have more of like the violence and kind of reckless behavior, a lot of those kind of questions and criteria definitely make more sense to occur in males. And you have like some of the manipulation and kind of callousness that is associated with the F1 factor of psychopathy, which is a little bit more common to occur in females, particularly females with BPD. So you kind of have some of this overlap. And also I think of like some of these manipulation behaviors might be more likely to be expressed by females in terms of like sex, for instance. And being promiscuous is associated with BPD. So you have kind of this overlap and difference in expression of kind of related traits, if you will.
Yeah, I mean, well, in terms of that one variable, promiscuous can trend for women that have borderline, but I think it also is for folks that have histrionic personality disorder as well, which I think also trends more female. I think, right? So I'm fuzzy on. It's been a while since I looked at this, but you're referencing in terms of psychopathy. You're referencing Hare's factors.
Yeah.
Right. And there's, God, how many are there?
Well, so there's factor 1 and factor 2, but they're often kind of split further. So then you have like erratic lifestyle, antisocial behavior, callous, and the interpersonal manipulation. Yeah.
So just for listeners, God, what's his name? Hare. What's his first name? I don't remember.
Bob.
Is it Bob Hare?
Robert, I think technically, but yeah. Bob.
I don't remember when created a. Oh, God, man, my memory's terrible for this. I used to do this stuff often. I worked at a forensic hospital for a while.
Oh, you did?
Yeah. So I mean, we did this stuff. So, and we used to have big debates about psychopathy and Hare's scales because there are issues with some of the data of which his scales are based off of. And then the last I was around this was that people were starting to move towards, which I think most people have that work with psychopathy, have really started to move towards a continuum model. That it's not, psychopaths have no empathy. It's like, not quite. maybe I'll put it in the notes. There's a fun paper. I have it somewhere in the cloud or something. Maybe you've read it, where they looked at the factors for 10 U.S. presidents. Have you seen this? Have you seen this paper?
I think I know what you're talking about. Yeah, I don't remember the details, but
they basically just looked at, kind of like what you're saying. I think it was trying to make their point of, for very like highly, 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 highly successful people in society, there are adaptive traits of psychopathy to be successful, which, you say that out loud in a sentence and it just makes people like, kind of panic a little bit. So kind of, I think the callousness, I think kind of the, what is it? The, something with the, not likability, but the, some element of being able to charm folks.
Just like being charming. Yeah. Like the superficial.
I can't remember all of them, and so it was, I think, I could totally have this wrong. So don't quote me on this.
Grandiosity.
Yeah, grandiosity is one of them.
Yeah.
If I remember correctly, again, I could have this wrong. I'll try and find the paper and put it in the notes. It's an old paper now. I think it's from 2005. I mean, I think it was George Bush was still president. I think it was Clinton. I think Clinton was the highest on some of them.
Oh, really?
And I want to say it was either Johnson or Nixon that was high on other ones, which was interesting. Which again, I think they make it in the paper too, which is like, these are obviously, U.S. presidents. We're not clinicians evaluating them. There's all those caveats, which it was kind of a fun paper. But the point is that highly successful people do load on these things. But either way, the factors for them are the data on which they're based off of. And I haven't seen the newest stuff on this. I'm not an expert in this field, but is that there's some issues with it. But then people started moving towards a continuum. So for your studying what you're saying, for folks that have borderline and people that have psychopathy, what are the things that you found, or what was the results that you saw?
Yeah, I mean, so I was interested in just, are there basic gender differences? Because I think there's a lot of research, but like there's not at the same time. There's particularly not a lot of research looking at the specific intersection of Bpd and psychopathy. There's a lot of like gender different papers specifically on psychopathy and then specifically on Bpd, but not as much about their overlap. And so I was kind of first interested in seeing, are there pronounced differences? So I was basically just using IRT analyses and kind of looking at if there were certain facets of psychopathy that tended to be more biased towards one gender or the other. And unsurprisingly, we found callousness tended to favor males. And that was probably my most pronounced effect. But the interesting thing, though, is females who are really, really high on Bpd tended to actually have higher callousness than males. So there was kind of this interesting effect at the right levels of psychopathy versus Bpd. I think the other main difference I found is, again, there's kind of this crossover effect with interpersonal manipulation items. So again, at lower levels of Bpd, it was more equal. But if you, at the higher spectrum of Bpd traits, again, those items tended to favor females over males. So it was kind of generally interesting, I guess. But then I was also kind of looking at how related Bpd and psychopathy were. So basically, I mean, they still emerged as distinct traits, but there was kind of a large shared commonality between the two, which is kind of similar to research that's looked at like antisocial personality disorder and Bpd, how they have a large overlap. And so that kind of mirrors, I think, more of the F2 components of psychopathy and their relationship with Bpd.
What specifically, what were the relationships between the two? Just generally in terms of between psychopathy and borderline personality?
Yeah, so I basically, I hate saying this because I have such mixed feelings about the bifactor model, but I basically just literally did a bifactor model and looked at, okay, how are these different facets of psychopathy and Bpd, related at this level? And basically, like the general factor accounted for like 70-ish to 80-ish% of the variance. I think I think it was a little bit higher for females. So females accounted for a little bit more variance than males. But so, I mean, that was a large chunk of variance, obviously, that they shared. But there was still more, I think, variance attributable to Bpd. So Bpd tended to be more of a still standalone construct compared to a lot of the psychopathy facets all kind of got subsumed right into the general factor.
That's really interesting. And how have you done other research on borderline personality specifically, or just on this comparative kind of analysis with antisocial, or excuse me,
So
with
other
psychopathy? Excuse me.
Yeah, so other than that, I mean, I did the looking at the P factor and Bpd and kind of how those trajectories
Hmm.
played out over time, because I was kind of interested in testing the idea, like, okay, is Bpd actually a marker of the P factor, or are there other reasons behind this explanation? So I was kind of, my hypothesis was basically that because Bpd is really heavily defined by a lot of internalizing and externalizing symptoms,
Hmm.
that it's kind of possible that you just have, again, these basic aspects of internalizing, externalizing that are kind of mixing together, and they're producing a set of symptoms that mirrors typical Bpd symptomology. So that was kind of what I was looking at basically over time. And it's a lot of models and a lot of statistics and a lot of word vomit on a page, but hopefully it will be published soon.
Is this
But,
is this a paper, or is this your dissertation research?
hopefully, well, both technically. So hopefully it will be published. I just actually sent edits to my advisor yesterday. So,
Mhm.
but yeah, it'll hopefully be published actually in two separate papers, because it's just too much stuff to fit in one. But
Yeah. Well, again, I'm okay at stats, but I'm not I'm not a stats whiz by any means. Just so people can understand it, this is probably very nerdy for listeners, but I think it's important. Uh, Bifactor model is of element of factor analysis, or it's separate. I can't recall.
yeah, I mean, I think it depends on who you ask, but generally speaking, yeah. I
Mhm,
think people just group it as a general structural equation model, but you
mhm.
could also, in fact, it's all the same stuff at the end of the day.
Yes, 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 yes. Well, the only reason I bring it up is because, for, if I remember correctly, factor analysis was, as a um, uh, statistical method, was designed by psychologists. I don't know if I have that wrong
That
about the
sounds
history of
right.
it, which basically it just looks at what's the underlying variable with all of these other variables and factors. And
Hmm.
so they're hard. Well, I don't know if they're hard to do. I mean, you would know more than I would, but they're time consuming. It is a step process, and you have to do all these things. But basically, you're loading in and loading out certain factors, and you're trying to understand what, when things are correlated, what is the two dependent independent variables, what are they correlated with, when you're factoring in or factoring out certain variables. So it's a multivariate process. And so when you're trying to answer a question or a hypothesis, you have to say, well, is it because of um, SES, race, gender, I guess genetics? I mean, you could load like 18 things on there. It's just so
Yeah.
many variables. You have to say, you're basically trying to understand what is the underlying variable, what is the thing that's connecting these two things, not for causation, but just see if it correlates. And for certain things, definitely intelligence, right? Because there's so many different components. That's very important to do. Um, I can imagine it's much harder when you're trying to look at things like personality or pathology. Um, but you don't like the bifactor model. Is that what you're saying? Is that
It
just because
has
you've been doing it for a long time? You're just like so
uh,
jaded. You're just like, fuck this. I don't want to do this anymore.
partially, I mean, definitely partially, yeah. But I think there's just how do I want to say this? I guess so. I think one major problem is, from a statistical standpoint, there's problems with it. It's, prone to overfit. It's really good at modeling garbage or junk. I think actually one of my professors, that's what he used to say. So you can pretty much throw whatever you want in these models, and a lot of times they do a fantastic job fitting the data, providing really good fit indices. And so again, like, people often use just that evidence as, okay, this is the right model for the data. Great, we're going to interpret it, blah, blah, blah. But in actuality, the model could be completely misspecified, not appropriate for the data whatsoever. And so we actually had a paper on this recently. I think it got published, I think, a year ago, that was kind of looking at considerations of using the bifactor model in psychiatric or psychopathology research in general, and kind of, weighing pros and cons. So sometimes it's appropriate and it's great and it can, tell you what you want to know. And other times I think it's just overly used because they're fun and easy to interpret, generally speaking. And again, like pretty easy to fit, I think, compared to other types of structural models.
Mhm. Yeah, I mean, again, I don't run them. I don't do research like that, but I think that I think they are good. I think they're really good for many things. I definitely think they're good for intelligence. Um, I don't know about other studies in psychological literature. Um,
Yeah.
so okay, so as you're plugging away and you're almost finished and all these things, I'd asked you at the beginning like what you want to do when you grow up, what do you want to do when you finish and all that. Um, but if you want, or if you care to, maybe tell us what is it about ways in which we can have better research within. I won't even say the social sciences. I'll say within psychology. How can we have better empirical research within um, psychological studies?
I think number one, we need to get better at dealing with feelings of being uncomfortable. And
Mm.
what I mean by that is I've noticed, I get just broadly speaking,
Sure, yeah.
again, like a lot of, especially like complex issues, like you brought up race and IQ. So a lot of these really complex issues that there's not necessarily a right or wrong answer to, I think people kind of shy away from, and they're kind of nervous to dive into these really difficult or sensitive topics. And so I think
Hmm.
that is my biggest thing is, and I think that's kind of what your podcast is about, kind of these, diverging dialogues and
Hmm.
how do we have a conversation about these difficult topics and
Right.
proactively work together to kind of find the truth. Because
Hmm.
again, you don't find the truth by shying away from difficult topics. So I think that's
Hmm.
number one. Uh, Number two is I think we need to get better at disseminating research to the public. So I think people have a very different view of psychology and what psychologists do and what mental disorders are versus what researchers and I guess even clinicians think. So that's two. Uh, Three, I have to actually think. I actually wrote notes on this too. Three, I think we need to be better at acknowledging our own biases.
Hmm.
I mean,
Hmm.
me included, I think it's really easy to get stuck on a theory that we really like or that we really identify with or
Yeah.
supports our data and blah, and just kind of get stuck on that and kind of forget to take a step back and kind of look for things that might actually go against our hypotheses and kind of again be more humble with our work and also kind of realize that oftentimes we might see causal relations where there are none, and that humans are prone to seeing patterns when there's really only random noise. Those would be my big takeaways, I think.
Hmm. Yeah. So I don't want to. Um, I don't want to necessarily go through one by one all of your points, but I do want to hit some of them or expand on some of them. Um, the first one. Hmm. So this one's tough, right? Because anything I say is going to sound. I'm going to be one of the elites, right? That's the only way I can think about this, right? So I kind of mentioned it earlier. Like, okay, I'm literally trying to think through this. Give me a second. So when somebody gets a doctorate historically and currently, there's quote unquote you're an expert in that field, and rightfully so. I mean, you spend 10 to 15 years studying one field. Now, I think everybody has to have a sense of epistemic humility, right? I don't know things. Like, I know a lot of things about this, but I don't know everything. I'm still learning all these things. I'm still trying to figure it out. But you know enough things to be like, yeah, I know some things, right? I should. If you go to school 10 years, you should do 12 years, you should know some things, right?
Hopefully.
Hopefully. Um, because of that, the training, hopefully, and the skills and the knowledge base you have, other people don't have, that don't do that. That doesn't mean that you're better, or that doesn't mean that there's higher value. That doesn't mean any of those things, right? So it does tie into kind of your second point. What it means, though, is I think this is true of anybody. So let's leave out, PhDs and PsyDs and all that for a minute. So my family's fairly blue collar, right? And if I go to my cousin who's a mechanic, I say, "Hey, my car is making a weird noise. Tell me what's going on. What the hell? I don't know. I didn't go to a trade school. I don't work on cars. I know how they conceptually function, but I don't know all the details, and I definitely don't know how to fix it. That's why I'm going to someone that's a quote unquote specialist. That's what they do all day. That's what they know. That's what they're trained for. That's what they have years of experience. And if I used to have a Saab. I recently sold it because it was just so many problems, and it was old, and they don't make them anymore. But sometimes it was a nice car. I just it was starting to become painful, and then it was like more money it's at that point where it's more money to fix it than the car is worth at that point. So I was like, whatever, I'm just going to scrap it. But I had to find a specialist that works on Scandinavian cars or whatever, right? Like, because that, even for like general mechanics, they're like, yeah. And like, if anybody knows anything about certain European cars, the orientation of certain things is wildly different than Japanese or American cars, right? I mean, even
it makes sense.
One time I was trying to change a tire, and it was backwards. It was like a foreign language. And then when I got it, I was like, oh, that's really easy. But it took me like half an hour because I just, it's a different way of doing it. Fine. It's not better or worse. It's just different. So there are many bad faith actors within our field. There are many people that just don't do good science. There are many people that might have a title, but they're just not very good. I mean, that's just true of any field. Okay. That being said, I think it is harmful to the general public inadvertently, and not productive or constructive, where people are talking about things that they don't know what the fuck they're talking about. So I don't know. I mean, I know, but I don't know everything about cognitive studies and intelligence studies. I have one of my professors that was like her thing. And like, anytime I had a question, she would be like, well, the base rates for this are blah, 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 blah. And I'm like, yeah, okay, I know what that is. I know all that. But she just went real in the weeds with it. And like, that's her thing. Okay. So within our field, there's people that really spend their life doing that. Fine. But I'm going to know more about that. You're going to know more about that. Rightfully so. How many classes? How many field placements? How many times have we given these tests? How many times do we have to do it by hand? How many articles do we have to read? How many labs do we have to do? That's the point. And I think it behooves people in the field that do know those things to correct for that. The problem, which I think you're picking up on, which I also notice, is there's too much friendly fire within the field. In academia, in research, there is a lot of gatekeepers, right? With the journals, with what gets published and what doesn't. And that's what happens when that isn't, when what academia is supposed to be or research is supposed to be, this various viewpoints, exchange of hard ideas, hard data, and not making everyone, someone that's doing eugenics or something like that. But when you're trying to understand the data, and it might be uncomfortable, we have to do that in academia and research, and then disseminate that to the public in clear, intelligible, understandable ways. When there's too much infighting and friendly fire, what gets spilled out into the public is garbage. And then that's where you have more misinformation. So the last thing I'll say is, when I saw the whole thing with Charles Murray and everything like that, like, you can say whatever you want about Charles Murray, but I don't find the things of what he's saying in the data inaccurate.
Yeah, sure.
Do I want to do that kind of that research or data? Not particularly. Do I care? Not really. Is it important? Maybe. But it's not statistically wrong.
Sure.
His politics are his politics, right? I think he's kind of libertarian and whatever. It's fine. Libertarians are fine. Like, it's just, politics aside, like, just on the data, that stuff wasn't, I learned that stuff 15 years ago whenever I was in grad school, and it wasn't controversial then. It was just like, oh, okay,
Right.
whatever. And all of a sudden, everyone's all up in arms. So, okay, so I've rambled on for this, for your first point. What are your opinions or ideas, as much as you want to say? Maybe not about that particularly, but just in general, or if you want to particularly about that kind of issue.
About kind of clashes between different people in the field, specifically?
Clashes between people in the field, but this idea that the responsibility for psychologists as quote unquote experts, or you want to call them elites or whatever, to be responsible in how they do science, and then how, kind of to your second point, they disseminate that to the public and say, this is what this is. And just kind of the general piece of that.
Gotcha. Yeah. I mean, I think, like you pointed out, when people are trying to disseminate information or research, especially on, important issues, it becomes difficult when the loudest person in the room isn't necessarily the most accurate. So I think it's really important that, one, especially like, again, hot topic issues, like even I think like social media use and its relationship to like depression or other adverse mental health outcomes is widely contentious, because there's like some people that are arguing that there is a direct relationship, other people are arguing that there's not one, blah blah blah. So I think, I mean, I'm using that example because it's a little less, I guess, scary as some of the other examples I could probably think of.
Sure.
But I think it serves the point of, okay, well, there might be these different opposing viewpoints, and that's fine, because that's kind of how science works. Like, oftentimes we have to go through a lot of different processes to kind of converge on what the actual truth is. But I think it's important to kind of convey those nuances to people.
Mm-hmm.
And unfortunately, I think the average person often doesn't want the nuances. They just kind of want the answer. Like, give me what's right.
That's right.
And it's like we kind of need to do a better job teaching society. And I think this goes way beyond psychology, that science is about the nuances. And there's not always like a hard and fast answer. And realistically, there's a lot of different things that you sometimes have to weigh and evaluate as an individual. And again, I think that's super relevant now with COVID and, all the confusion on masks and the vaccine and all this stuff. And again, like, it's important to teach people that, again, science is a process. And that way they're not as confused when answer A kind of changes to answer B and then back to A. And then, you know what I mean? So
that's right.
Yeah. And I unfortunately think, because, we as human beings have this tendency that we want to be right and we want our work to be correct and accurate and whatever, that we, naturally kind of resist this idea that, okay, we could be wrong, and, the importance of kind of challenging our own beliefs, even though that's probably going to be more beneficial for society in the long run.
Yeah. And I don't know. I hate when people blame everything on mainstream media and or social media. I think it's a component for sure. But there's always been, infighting. There's always been misinformation, right? I mean, the whole reason why there's anti-vaxxers was because of one study that was a farce, and the guy, came out and said it was, and he was penalized, and blah 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 blah. One study. 30 years later, there's a whole cult following around it. But so, I mean, it's not a new thing, but it does feel, kind of on steroids now, and it's just like, how do we do that? How do we explain nuance? Because I think most people, I mean, that's just hard to do because you have one of two things that happen, I think. It comes out as here's a bunch of elites using a lot of big words, using a lot of terminology I don't know, talking down to me in this sanctimonious kind of way. Or it gets extremely watered down and you get a bunch of people that do pop psych self-help nonsense. And then that's worse, I think, because then it's like, now it's, there are many inaccuracies and there's a lot of misinformation now. And now behind, people hide behind, or they use a title or something. And, if you're trying to trust someone that says, hey, they have this and this and this, and they wrote a cool book and whatever, and they're selling it this way. And it's just, I get there's some element of like selling things. And so you want to, you're not going to, there's some ways of dressing things up that, make it presentable. But, when it's just gross inaccuracies or really, really tough stuff, that's worse because then you have to correct for it and dispel all of those myths. And it's just more work in some way. So I think what you're saying and what I'm saying is, how do we find the middle way where there's nuance? But even for the first point, right? Back to the first point, how, I guess that kind of with colleagues or with academics or with researchers, how do you think you have uncomfortable conversations? How do you have uncomfortable, not conversations like, kind of like over a happy hour or something, like, academically, how do you say like, look, here's the data, this is what this says. How do you think we present that, or how do we tackle those kinds of things? Or can we? I don't know.
Yeah, I think, it depends, honestly, on how receptive other people are to different viewpoints. And I think also how the person presents the information. I think there will always be topics that are just taboo, or, topics that people don't want to dive into because of the implications. And again, and it makes sense, but at the same time, a lot of those conversations are probably some of the more important ones.
Mm-hmm.
But it's funny because with a lot of my colleagues, I'm often labeled the contrarian one, and people just, I think, expect me to have different opinions as them. And in many cases, we often agree fundamentally at whatever it is we're talking about, but we might just kind of differ slightly in the kind of little details. Or, I might have read something that's different from them, and I bring up, point A that they haven't considered, or vice versa. And again, I think if you're skillful, I guess, and careful about how you bring some of these things up, and you do so in a non-defensive way, and kind of ask questions and ask, or try to be curious instead of again on the defensive, or have your guard up, that tends to work better. But at the end of the day, I think there are just a lot of people who are not willing to discuss things that are kind of out of their comfort zone, or kind of consider different ways of thinking about topics. And that's just unfortunate, but that's, I think, kind of how it is sometimes.
Yeah, I think again, there's always this kind of weird, polarization that kind of just happens. So on one hand, what I see people doing is, so I can't help but think that there is kind of temperament and personality that comes into play here. With academics or people that are thinking about these things. So what you'll see, and I mean, you've seen this too, probably. This is my kind of conceptualization of it. Even in a societal general way, you'll have a group of people that will actively ignore hard conversations or hard data, or do a lot of gymnastics to explain out of it, and they'll ignore it and really, just not even try and hide how they cherry pick the data and the things they like because it fits their system or their model or their ideology or whatever.
Yeah.
That's annoying. That's really annoying because, these are usually the people that are going around saying like, trust the science. And it's like, yeah, until you don't like it. And then, that's not how it works. And you can't expect other people to come on board when they present hard data and you just want to say they're bigots or racist because of the data that's there. Like that's not how you do science. And you can't say trust the science on some things, but not the ones that don't agree with you. And even saying that point, they can't even hear that, right? Which is really frustrating. there's the other side of things, which is equally annoying, which is, I mean, people that they perseverate. Like, I know people now that aren't in the field of psychology, or even maybe are loosely, and they're obsessed with race and IQ. It's like, it doesn't need to be obsessive. Like, we don't need to, like, I don't want to see every post about this. I don't want to see, articles about this all the time where people are always looking for this. It's like, it's just kind of hyper focused. You see, here it is, and just keep going to like the counter narrative. And it's like, that's not helpful either. Like, if you're looking for something all the time, that's just as harmful. And I think my conceptualization of this is, those are just folks that have, again, I'm sort of kind of grouping people inadvertently, but I do think that there's certain temperaments for people that do one or the other, right? And maybe there's a third or fourth different category. I don't know, but that's just kind of observational what I see. That happens a lot. I see these people that they're real amped up or animated about one thing, and that's all they talk about. That's all they post about. All the negative, all the like, anti this or that, and that's it. It's just all day, and it's like, sure, come on, let's create. Let's find something. There is nuance as well, right? And and I feel like on both sides that doesn't happen, but it's, I'm less sanguine about some of this stuff because it's just, the center and the middle, and, being moderate about whether it's politically or whether it's in other topical areas. It's just not sexy. It's not exciting. People don't want nuance. It's kind of like you were saying, like, they just want the hard answer. They don't want, like, well, it's this, but then it's also this, and we have to factor in all of these other things. And so it's kind of, it's a lot of things. They just don't like that answer, right? It doesn't fit.
And it makes sense. Like, if you look at, not to bring up politics, but just political leaders in general, typically the ones that are successful, they have a hard stance. They're very assertive, and they're like, this is how we're going to do it. There's not a lot of like, well, we might do it this way, we might do it this way, kind of thing. Yeah, like you said, like, people don't like that kind of approach as much. But I think it's definitely necessary, or even if you are going to take like a hard stance, at least like try to integrate some things that are kind of different from you, or views that are dissimilar. Like, I think a great example, I was at some like conference a few years ago, and someone was looking at, I guess, like predicting views on abortion or something. And they were, I think typically when people study, I mean, it's not my area of expertise, obviously, but I think typically when people study abortion or kind of ideas towards abortion, it's usually like people who are against abortion are religious, or they're conservative, or they're, whatever. Like, they have those very typical kind of views. And I guess what this individual did is they kind of looked at both more democratic, like more liberal, I guess, perspectives, which a lot of people are like, wait, what do you mean? Those don't exist, because all liberals are, pro-choice.
Right.
But I think like the idea of life being sacred, or I can't remember all of the details, but like spirituality, like some of these other factors that weren't considered previously, by considering them and adding them to their study, like explain so much more variance than the just typical perspectives. So I thought, I mean, that's just a perfect example of improving your field and improving your studies by just exploring things that are kind of outside of your bubble a little bit.
Yeah. I had I talked about it with I think I talked about it with Corey, about how much of the social sciences, at least in academia and I guess in research, this is 90% liberal. There's not conservative thinkers or people are doing research, and it's not happening, and it's not by accident. You don't get to 90-10 by accident. And I'm not saying it has to be 50-50, but it definitely should not be that disparate, though, because you don't have viewpoint diversity, and that's what you need. You need viewpoint diversity, especially if you're doing science, which is supposed to be neutral. In some ways, you're trying to be objective. I think that's what most people try and do in science, or should be doing.
It's the goal, anyways.
Yeah, right, because there's problems if you don't have the spirit of that aspirationally, at least. Yeah. So, and I think that's, I think that's the thing that's important. And I'm even, look, if I take a charitable reading on this, like I'm fine with people wanting to like have a phase. They learn some data, they get animated, get a little zealous. Okay, fine. We've all been there, right? I'm not that old. When I left religion and I went from theist to atheist, I was pretty militant, hardcore atheist for like, a year. I wasn't publicly like, saying horrible things, but, I was just pretty like, just triggered. You say anything about, religion, and I was just like, oh god, bullshit, blah blah blah. It's just like, a lot of animus towards it. And I still think the doctrines and the dogma is pretty pernicious for the big three. But I do think that there are many potential positive aspects of religion, and there are I greatly respect people that do believe in religion and how it really is helpful for a community and some sense of spirituality, and for some people it's a moral compass, and you know on and on and on. Some of the research and data shows. So it's like, okay, well, maybe not being so militant and trying to be blasphemous to provoke and be intentionally blasphemous is not helpful. So and so then eventually you balance, you moderate. So maybe some people that's their process, but it does feel like it's just been, I would say, 5 to 6 years of just this like continuously escalating kind of double down more, and how it just bleeds out into every area now. It's in big tech, it's in corporate, it's in academia, it's in education, it's in politics, obviously, and it's
Yeah, I
it's
feel like there's
frustrating.
been more of this. At least I've noticed more people relying on anecdotal evidence to kind of support claims against things, or I don't know. Maybe I've just spent too much time on Twitter, but that just seems to be, like I think you mentioned earlier too. People obviously like to confirm their own biases, but it's like
Hmm.
I've
Hmm.
seen so much just actually like decent data too, like good quantitative data where people are just completely rejecting because they have a random experience that isn't consistent with the conclusions of the paper. And I
Yeah,
feel like that's
yeah.
becoming,
I mean, I I have never talked about it as much as I have in the past 3 months. But I have. Oh, it's becoming a strange thing now, kind of organically, if you will. Almost every other episode, I'm talking about quantitative versus qualitative data, and it's just like, look, we need both. Like, they're both important. Like, people that are just hard quantitative, it's like, yeah, sure, I get it. Like, I'm trend and lean more on that. Clinical psych is my world. Of course, I do. But qualitative stuff super important. You need that. It gives it more of a robust uh, set of data, or can, and it's important and it's necessary. And I've seen that stuff too. I interact with people that do that. It's just like lived experiences and qualitative data all the way down. And we don't care about quantitative stuff. That's the master's tools. And it's just like, no, it's not right on either side. You need both.
yeah,
You need both aspects of it. And that's, again, that seems that's that those conversations in that way are really boring to me and not helpful. It's just a waste of time, in my opinion. It's just like, look, they're both important. Everyone that's worth their salt recognizes they're both important, and let's do both. So don't dismiss the quantitative stuff because it doesn't agree with whatever you want. And other people on the other side, don't dismiss the qualitative stuff because it's not, hard numbers and data, and I don't care about your ethnographs. It's like, yeah, they're all important, right? They all have utility, and that doesn't necessarily mean it needs to or it will for every single study. There are some studies that are just more designed and pushed for quantitative stuff. Okay, and there's some where it's more qualitative. I don't think it devalues it. I mean, uh episode I'm going to release hopefully this month, I talked with a sociologist that does um marriage and divorce studies. Sociology is heavy on qualitative stuff. I mean, that's their bread
yeah,
and butter. But he also does quantitative stuff, and he was just like, yeah, people have been having this argument for 50 years, since the 60s. They've been having this argument. He's just like, it's always been there. It's just kind of, again, amped up to 11. But yeah, you need both. Duh.
yeah, yeah.
I
I
mean,
mean,
you need both.
definitely. give you different pieces of information.
Yeah, so I think that's important. Okay. Anything else that you want to say or cover or we didn't get to, or maybe I didn't ask you directly? Anything else that you wanted
Anything else?
to share?
Yeah, I mean, I think we covered most of the stuff. I think I had on here stuff about BPD on whether it represents an actual construct or not. That would be a true contentious debate that I think most people would, again, not agree with me if I said BPD isn't really a thing.
Which
I don't fully believe, but
yeah. Well, just for the sake of being, I guess playful, give me the skinny download of that. What you mean?
I opened up a can of worms. Basically, there was this.
Well, now I'm intrigued.
Proposal.
I'm curious now.
Yeah. Well, basically, again, these were basically conclusions derived from different factor models, if you will. But the idea, again, was because BPD is like this one weird construct that loads really, really heavily on the general factor that, again, maybe it doesn't actually represent a specific disorder or construct. Maybe it's just, again, kind of the result of all these other different influences. So, and I think to an extent that might be true, not fully, but I think some of the core symptoms of BPD are very pervasive across a lot of different disorders. So, like the hallmark symptom of BPD is kind of this affective instability, problems regulating your emotions, which you see in so many different disorders. Mm-hmm. So, I think, and also, I guess another common one is like chronic feelings of emptiness. Like, there's a lot of individuals, who don't have any personality problems who have that feeling, or, identity disturbances, things like that. So, I think the idea is that, a large chunk of BPD may easily be defined outside of BPD proper as a construct, if that makes any sense. And statistically, that has had some support as well. But I think that's a pretty debated argument that, I don't know. I think any clinician would be like, what are you talking about? Like, of course, BPD is a construct. Like, I see it all the time. And, so it's kind of a interesting debate.
Yeah. I hear your point. I guess the only pushback I would have is, well, what happens when you have a person that has, I hate saying this, but the right cocktail and cluster of all these symptoms of which we understand as borderline, then we typically call that borderline. So how would you explain that then, right? Because it's like, yeah. I agree with you. I think there are major features that you will see in other folks. And so it's like, yeah, this whole construct is, maybe, I think it's fair. It's up for debate. That kind of goes to maybe a little bit of we didn't talk about it, and I don't know how much you know about it. I know almost nothing, but there is a alternative taxonomy and criteria for personality disorders that's in the appendix of the DSM-5, but isn't officially there.
I think you messaged me something about this, and I was like,
yeah,
maybe.
I don't know anything about it either. I just know it exists. I don't really use it. I think there's maybe a few people that do, but maybe that's what they're trying to push for. But so I guess that would be the only pushback. But then there's the like even more abstract thing, which maybe is what you're kind of getting at is. So this is a philosophical argument, which is we're trying to explain experiences. People have certain mood states, they have certain presentations, they have certain sequelae, they have certain ways of how they are operating. And we call those things this. What we call it doesn't really exist. That's what we have termed it, right? This is kind of the argument that Wittgenstein makes with language. That we're using those things as representative signs and symbols to understand the cluster of something, which is fine. That's how we quantify things. But we should, I think this ties in kind of with the other things we were saying about like science in general. Like we get too attached sometimes to our stuff. And it's like, well, wait a minute. Sometimes we just stumble on a finding or we stumble on something where we have to reconceptualize it. And that doesn't make sense anymore. That made sense as a stopgap, or it made sense for trying to quantify things. But then as we understand science and we understand things, we have to be more abstract and say philosophically, maybe this just needs a different taxonomy. This needs a new way of talking about it. And, this is probably inaccurate. Is that somewhat of kind of what you're saying?
Yeah. Because I think with BPD, like I'm not saying that I think BPD isn't a legitimate construct, but I do think, again, like having a more nuanced approach to it is beneficial, especially because I think there's some work in adolescence that kind of shows this as well. You have a huge spike typically in BPD symptoms in adolescence. Like that's pretty common. And I think that is
Late
one kind of a,
adolescence, right?
yeah.
Like 15,
And I think
16,
that
17.
Yep, yep. And I think that one is a product of just how insanely crazy adolescence is. But also, again, like,
Right.
you typically have internalizing and externalizing types of symptoms that will precede the expression of BPD symptoms. And
Mm-hmm.
again, kind of what I said earlier is a lot of times those internalizing, externalizing features look
Mm-hmm.
very similar to BPD. So I think for that would also kind of explain why you have a lot of people who kind of grow out of these personality problems, if you will.
Mm-hmm.
So for some people, you might have BPD like features primarily as a product of having these other types of psychopathology that kind of, again, over time manifest in a way that's similar to BPD, versus other people might, legitimately have a lot of these core central features of BPD and continue to have those features, over time.
Mm-hmm.
So again, kind of approaching things from different angles, I think in that context is important because also like from a treatment perspective, if you're really focused on these BPD symptoms, those might not be as important at this time period because, again, if those are more of a byproduct of these other preceding symptoms, then those
Mm-hmm.
preceding symptoms
Mm-hmm.
probably make more sense to target versus, other scenarios that might look different. So I don't know. It's complicated. Everything's complicated at the end of the day. But
No, I like it. I think it's right. I think people get too fixated and they get too attached to certain things. And I know people that are in that world get really attached to these criteria or this way of classifying things, and it's like, well, okay, yeah, it makes sense, it works, but um until it doesn't, or until we figure out a different way of conceptualizing that's more accurate or closer to really experience of a person, in these ways of pathology. It's like, I don't want to be too off topic, but it's like, the disease model of addiction. It's like, well, I mean, yeah, I hear that, but that's not necessarily conclusive. I know it's the popular one, but that's not entirely conclusive. There's a lot of, at least in research, there's a lot of fair criticism for that way of constructing it. And I understand for many people, there's kind of battle lines drawn on this stuff, but for a lot of people it's very easy to explain, and for the common folk it's really easy to explain and all that. But I'm not, again, I don't do substance abuse research, but I've read a few of the different theories and disease model. I get it, but I don't, it's not overwhelmingly compelling to me either. So
have you heard Sally Satel's arguments about that?
I know the name,
About
but
like
I don't know her
addiction
argument.
as a brain disease?
Yes,
Uh,
yes, 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 yes.
Yes, I love her. I think she wrote a book with Scott Lilienfeld, and which I have not read, but it's on my list.
Hmm.
But I heard her talk once, and I mean, she kind of talks about that subject in general, just about the problems of kind of conceptualizing anything as a brain disease, and
Hmm.
particularly, obviously, like substance use and kind of the harms of that. It was very interesting. And she kind of talked about the opioid crisis as well. I mean, that's a whole other can of worms, but
Yeah,
it
yeah, yeah.
was definitely, and again, like you said, it's a really think contentious topic that people get really heated about very
Uh,
quickly.
Yeah, right. I mean, well, yeah, I mean, that's right. And that's my point of the example, is that people get really attached to something, then they don't want to let it go when there's something that's like, okay. And again, I'm not saying that every shiny new thing we have to be like, yes, let's do this new thing. Like, you want to test it and retest it and see and look at all the data, and is, efficacious and is it effective, and, okay. And then if it all that holds up, it's like, okay, let's readjust. And some people don't want to let that go. Um, I guess one of the last things, just because I'm curious what you think about it. I, again, sort of like yourself, I've all my life been kind of known as the contrarian as well. Mostly because I just ask a lot of questions and I have a very critical, analytical mind about stuff. So I'm just kind of like, I get it. But wait, what's all these things with everything? Even my, like, the
Mhm.
positions I hold, I'm like, maybe this isn't right. maybe I've been thinking the wrong thing about this all the time. So it's always in process. But DBT, you like it? You don't like it? Um,
DBT.
mhm. I have my own opinions about it, but
Interesting that you asked that question. That's a loaded one.
I know it's loaded.
You
Sorry.
know,
Just in
no,
general.
it's a good question.
Just in general.
I have mixed feelings. So I think Marsha Linehan and her, well, obviously she kind of cherry picked a lot of information from a lot of different places. And I think she's, acknowledges that.
Mm-hmm.
And I mean, I think she was really smart in the way she kind of packaged it all together and kind of pulled from all of these different frameworks. And I think, the way it was manufactured was really genius.
Mm-hmm.
But at the same time, at the same time, I have to get better at my and instead of but statements, my judgments and all of that good stuff. But, and I think at the same time, there's just aspects of the skills that I'm just like, why do people think this works? Like, and some of it, again, I think I said this earlier, is just so fluffy and just, I think, again, like you really have to buy into it, I think. And
yes,
a lot of it is, to me, I struggle with. I have to really, kind of
You're
check
not a
my
true
own
believer.
biases.
You're not a true believer.
I am, but I'm not. I think honestly, at the surface level, a lot of the skills are honestly useful for anyone, right? Like a lot of them are just basic communication skills, interpersonal skills, like how to regulate your emotions. And then there's some other stuff in there where I'm just like, this is a little odd to me.
When you're feeling really overwhelmed, emotionally overwhelmed, you need to stick your face in a bowl of cold ice water or stick your hand in a bowl of ice cold water and all that stuff. And that will instantly activate and just stop all the flooding and all that stuff, right? Isn't that one of the techniques? Right?
Yeah. Tip. Yeah. The changing your temperature. I mean, also like the willing hands. I think that one, I remember just teaching group therapy and having to like model these things. I'm like, okay, well, I have to look bought in because that's not going to be good to the patients if I'm just like, okay, we're going to go over willing hands today. But I'm just like, maybe sitting with my palms face open or palms up and just, trying to be one with the world and being mindful. I don't know. I'm like, maybe this will work for some people. But for me, I'm just like, this is funny to me. Like, I don't, this is weird. But perhaps that's just me being willful. I don't know. And also, I guess, I will say one of my favorite things, though, out of DBT is behavioral chain analyses. So I think those are extremely helpful for people when used correctly and kind of, building insight into, okay, why are you doing these things that you don't want to be doing? And diary cards, I think, can be useful-ish.
Yeah, depends.
It depends. I agree.
Depends.
I think I like the idea of tracking things, particularly like mood states and those types of things, which aren't necessarily on the diary card, at least the ones that we use. It's just like tracking skill usage, which I feel like people are often motivated to just like fill in things to make it look like they're doing stuff when they're not actually doing things, which is kind of a problem. So I guess the moral of the story is I like DBT and I think it is useful. Do I think it has some flaws and some areas of improvement needed? Yes. And I think one of my biggest issues, but this could be true for really a lot of different therapies, is it's really hard for people who don't have a lot of insight or people who may not have a certain level of like cognitive ability. So I remember doing DBT actually in a forensic hospital. And, you just had a lot of people who were a little bit lower functioning and totally fine. But for them, it was like, not connect the dots. And it was really, really hard to kind of boil it down to something that's really simple for them to understand. Like, I mean, how do you teach radical acceptance? Like the concept of accepting things that are out of your control is both simple, but also kind of difficult to teach someone how to actually do that in practice. And so for me, I always found that really difficult of like, okay, how do I package this in a way that makes sense to everyone,
Yeah, well, right. I mean, when I did it for a little bit, when I worked at an inpatient hospital and right, DBT was all the craze and everyone was doing it. And, it's like, folks in inpatient hospitals are very sick. And so on top of, floridly psychotic and maybe compliant with medication, usually there's a co-occurring with substance use, long term, right, which has impact. Usually there's physical ailments, and then most folks there are intellectually disabled. They're having IQ of 62, 55. How am I going to do radical acceptance, right? Everything needs to be very concrete for folks in inpatient hospitals, or most people in inpatient hospitals.
Right.
And so, you have to adjust and adapt. I guess I'll just say about DBT, real quick, I think it's fine for what it was designed to do. I think it's designed to work with folks that have borderline personality disorder. I think it was designed in a group setting. Is that mostly true?
That sounds right.
Because how it initially started, at least. And I don't know if it was outpatient or kind of an intensive outpatient or if it was inpatient. I can't remember how the setting was where it started. I forget at the moment. But I think it's good for those. I think for the initial intention of where it was designed, it's fine.
Mm-hmm.
I mean, I have worked, I work private practice now, so it's just like I've had, where I used to work at a private practice, colleagues that would, be pulling out the DBT workbook with, very high functioning, quote unquote, neurotic patients, and I'm like, why are you doing this? They're not borderline. Like this isn't even empirically supported for, normal, people or people that don't have a personality disorder. Like, why are you? It's like, yeah, sure, you can use some of the techniques, and I guess it has some general applicability, but it's just like I don't know. You can run into, if you really want it to be kind of a hard ass, you run into some ethical issues. Like, why are you doing a treatment that's not empirically supported for that population?
Yeah.
I don't know. And so, right, it's like everything else. People that really love it swear by it. It's like, it's Jesus turning the wine into water into wine. I mean, it's amazing. It's a magic pill. It's a potion. It's amazing. It just fixes everything. It's like, does it? I don't know. I'm not a true believer. I've looked at some of the research on it and some of the stats on it. I'm like, it works for what it was designed to work for, but just trying to apply it to all groups and all populations, I haven't kept up with the research. Maybe there is some good stuff with it, but yeah, I've seen people that just like use it unilaterally for people, and I'm like, I don't know about that.
Yeah.
Even for some folks that have borderline personalities, it's not always effective, and it's just like, that's what you're going to do. DBT. It's like, yeah, you might start with it, you might use elements, but it doesn't mean you're going to do it that way. Each person is different.
Right. No, exactly. And I think there has been studies too that have looked at, differences between CBT and DBT for borderline patients in particular, and have found same results, so I don't know, maybe that's just a testament of common factors, or other things, obviously, that affect people's, improvements in therapy and whatnot. But I think, like you said, like everyone is different. And even if you have similar symptoms, how people digest what you're giving them and kind of the skills you're teaching them obviously varies quite a bit. So I think those kind of individual differences are really important to keep in mind, even though I think other people would be like, no, stick to the modality. You're not supposed to deviate, follow the protocol and whatnot. But I don't know. It's just like in modern medicine, we don't always apply the same principle or the same treatment to everyone who comes in with like a heart condition, like there's right. So like, I don't know why psychotherapy would be any different.
Yeah. I mean, I see it the same way. I don't get that. I don't know. It's a, it's a strange thing. I had a conversation earlier, about, people still fight about, which camp do they have allegiance to? Are you Freudian? Are you CBT? Are you family systems? Are you, ACT or, whatever? And it's just like, look, I don't give a shit. They're all the same in some ways. They're all empirically supported, or most of them are the big ones. It's like, just have a way of conceptualizing someone when you're doing treatment and use it appropriately, and it's fine. I don't give a shit. It's fine. Like, it's not, people don't need to fight about it. Like, it's how you see the world. It's how you see people. It's fine. Like, it's, I think people, and being flexible to being like, hey, work within your area of competence, but flexible of like, yeah, I can use interventions from a model that's not mine and still conceptualize people a certain way. I mean, I think that's totally appropriate. So
yeah, for sure.
People get too attached to their belief systems, I think.
Agreed.
Okay, so you've been very generous with your time. So I really appreciate it.
It's been fun.
Yeah, it was a lot of fun. I don't talk about this stuff at all really anymore, so it's very nice to kind of exercise that muscle I haven't used in a while. And you obviously know way more about this stuff than I do, and so it's very helpful and educational for me as more than anything else, and hopefully for listeners too. And it was so much fun. Again, I love always getting in the clinical arena and kind of nerding out about that stuff in my field and everything. So that's always a lot of fun. Where's a good place for people to find you, or either, stuff you've published or online or whatever? Where can people find you if you want them to?
So I do have a website that I primarily use just to post R code. So if people want random code for things, definitely check out my website. It's just alliechoate.netlify.com. It's also, my Twitter handle is Allie M Choate. So I think my website's also listed under there. That's my Twitter. My full name's Alexandria. So if you're interested in my research, I guess you can Google me. Hopefully there's other stuff that's coming out soon that's being published. But yeah, I'm also on LinkedIn now. I just got LinkedIn a couple days ago because my boss at the it's so weird. I'm like, I don't understand this corporate America stuff, but yeah, she's like, oh, you should get one. It's good. And yeah, so I'm on LinkedIn now as well.
Well, again, thanks so much for coming and talking about this stuff. I really had a lot of fun. I really enjoy it. And so it's great. I think you do good work, and it'd be fun to see what other kinds of things you do, in the near future and long term and stuff. So you're always welcome to come on and chat about anything you want. So hopefully we can do it again.
Yeah, thanks so much again for having me. This was great.
Okay. All right. Thanks.